Assalamu alaikum. Let's jump into the land of the medicine. Start with CTS. Very common topic, that is carpal, that is carpal tunnel syndrome, CTS. Carpal tunnel syndrome refers a neuropathic. It's a neuropathic symptom like pain, paresthesia, weakness caused by the compression of which nerve? Median nerve. So is hap carpal tunnel happens due to compression of the median nerve as it passes through the carpal tunnel. This median nerve passes through the carpal tunnel, a narrow anatomical passage in the wrist bounded by these narrow anatomical passage in the wrist. It is bounded by the dorsally by the carpal bones and transverse carpal ligament palmarly. So dorsally carpal bones and transverse carpal ligament on the palmar aspect or palmarly. It is a very common compressive neuropathy. If we look at the anatomy of the carpal tunnel, if we look at the anatomy, if we look at the boundaries of the carpal tunnel, if we look at here the boundaries, if we look at, if we go through this picture, look at the boundaries, the floor of the carpal tunnel, the floor of the carpal tunnel is formed by the 8 carpal bones. So floor is formed by the 8 carpal bones, and 8 carpal bones you can remember by the mnemonic that she looks too pretty, try to catch her. So scaphoid, lunate, triquetral, pisiform, trapezium, trapezoid, capitate, hamate. So it is formed by the floor of the carpal tunnel is an arch, formed by the 8 carpal bones, and the roof is of the carpal tunnel consists of transverse carpal ligament. This is the transverse carpal ligament. This here, the yellow one, is the median nerve. So the roof of the carpal tunnel consists of transverse carpal ligament. So floor formed by the 8 carpal bones and the roof formed by the transverse carpal ligament, all, which attaches the carpal bone. This transverse carpal ligament attaches the carpal bone laterally, scaphoid and trapezium, laterally scaphoid and trapezium, and medially by the pisiform and the hook of the hamate, medially by the pisiform and the hamate, medially by the pisiform and the hamate, and the laterally by the scaphoid and the trapezium. So laterally by the scaphoid and trapezium, and medially by the pisiform and the hook of the hamate. If we look at the contents of the carpal tunnels, the carpal tunnels primarily functions as a conduit for 9 flexor tendon. What are those flexor tendon? Flexor digitorum superficialis 4 tendon, flexor digitorum profundus 4 tendon, and flexor borealis longus 8 tendon, 1 nerve. So it acts as a the primary function acts as a conduit for 9 flexure tendons that helps bend the thumb and the finger during the forearm contraction. The transverse carpal ligament helps prevent these tendons from bowing at the wrist. So the transverse carpal ligament actually helps prevent these tendons like the 9 tendons from bowing at the wrist. The median nerve must pass through the tunnel to transmit sensory input from the first 3.5 digit as well as motor output of the muscles needed for thumb abduction and opposition needed for thumb abduction, opposition, opponensis pollicis, and the flexion. So median nerve, uh, the median nerve must transmit through the tunnel to the sensory input in the first 3.5 digit as well as motor input. So motor input for thumb abduction by the abductor pollicis brevis and the opposition opponensis pollicis and the flexion flexor pollicis brevis. If we remember these three, that the carpal tunnel con the carpal tunnel contains that flexor pollicis longus. It helps flexor pollicis longus or flexor pollicis brevis helps in flexion and flexor. Okay, if we look at the pathophysiology of the carpal tunnel, because of the carpal tunnel's boundaries are rigid, hard bone. Boundaries are the rigid and the hard bone fibrous ligament. There is little room for the expansion. Therefore, any process that increases the volume of the tunnels, any process that increases the volume of the tunnels contains tunnel contents and reduces anatomic size can elevate intrapleural pressure resulting in median nerve compression. Compression induces microvascular injury, venous congestion, edema, inflammation resulting in nerve dysfunction due to ischemia and demyelination. Sustained severe compression can cause axonal loss, which can manifest as severe disease. CTS typically affects sensory fibers. Very important talks like um, CTS. Okay, okay. So CTS actually affects the sensory fibers first. Very important. CTS actually affects sensory fibers first. Sensory is more sensitive to compression followed by the motor fibers. So CTS actually affects sensory fiber first, then the motor fibers. Repetitive wrist movement tend to exacerbate the median nerve injury because position change can elevate intrapleural pressure. Extension flexion can increase the pressure up to tenfold. Repeated compression creates a vicious cycle of worsening nerve edema, inflammation, and ischemia. Risk factors is although CTS is an idiopathic, there is an increased risk of CTS with environmental factors, medial conditions, gender differences. Environmental factors can uh, lead to these CTS like occupations that increase risk typically involves wrist movement with prolonged extension and the flexion, and excessive force or repetition or mechanical vibration or pulsation, manufacturing, construction, food processing, although often implicated in symptoms exacerbation, light duty office work, typing, computer use does not independently cause CTS. Medical conditions like median nerve compression at the wrist is associated with some medical condition which that either increase the volume of the carpal tunnel contents or reduce the anatomic size. Increase the volume of the carpal tunnel content including pregnancy, fluid accumulation, diabetes mellitus tendon, glycosylation, obesity, excess fat. These actually increase the volume of the tunnel. So carpal tunnel, the median nerve compression happens in two pathophysiology. Increase the volume of the tunnel. Diabetes mellitus, tendon glycosylation, obesity, excess fat, rheumatoid arthritis, synovial inflammation, hypothyroidism, mucin buildup, and amyloidosis. Beta 2 microglobulin accumulation with hemodialysis. And reduced tunnel size can occur insidiously from osteoarthritis or acutely from trauma, lunate dislocation. So osteoarthritis, if there is osteophyte formation, it can reduce the tunnel size and thus cause this pain. And if lunate is dislocated, it can compress the median nerve. So lunate dislocation can compress the median nerve. So these two processes can reduce the tunnel size. These two processes can reduce the tunnel size. For gender, females are more susceptible than the male, 3:1, possibly related to generally smaller carpal tunnel sizes in female patients, making them more susceptible to intratunnel volume change. So females are more prone, more susceptible than the males, 3:1. Clinical presentation. If we look at the clinical presentation, CTS is hallmarked by pain and paresthesia, tingling, burning, numbness in the median nerve, sensory distribution in the first three digits, and the radial half of the digit. So the if we look at here, if we look at this picture, if we look at this picture, this is the carpal tunnel syndrome median nerve sensory distribution. Look here, the palmar digital branches, first three and a half, and the radial half of the digit, because the median nerve palmar-cutaneous branch arises proximal to the wrist and passes over, not through the carpal tunnel. It passes over the carpal tunnel. CTS does not affect skin sensation over the thinner eminence. So carpal tunnel syndrome does not typically affect skin sensation over the thinner eminence, as because the median nerve, the palmar cutaneous branch, arises proximal to the wrist and passes over, not through the carpal tunnel. So sensory involvement usually not happen. Clinical course like onset is a gradual intermittent symptom. The pain and the paresthesia typically worsen at the night, likely due to prolonged nocturnal wrist flexion. Mm, or supine fluid redistribution causing higher tunnel pressure. May awaken from sleep. With progression, symptoms can become persistent throughout the day. The dominant hand is most often affected, and bilateral CTS is common. If I look at the aggravating factor or relieving factor, symptoms often provoked by activities involving sustained wrist extension and flexion like driving, typing, increase the carpal tunnel pressures. Transient relief reported by shaking the affected hand or holding it under warm water. So the pain improves shaking the affected hand or holding it under the warm water because motor fibers are less sensitive to compression than the sensory fibers. Evidence of muscle weakness typically signals more advanced disease. Severe CTS impairs the median nerve innervation. It impairs the median nerve innervation. If we look at this picture, if you look at here, it is the median nerve innervation in the hand. This is the median nerve, this is the palmar branch, sensory to the palm. It goes under the carpal tunnel. Okay, recurrent branch, motor to thinner eminence. This is the digital nerve, lateral 2.5 of the lumbricals. Okay, clinical finding. There may be thinner eminence atrophy. There may be weakness of thumb abduction, weakness of thumb abduction and opposition, weakness of thumb abduction and opposition. In cities, there is weakness of thumb abduction and opposition. Patient may describe symptoms of weakness or clumsiness, typically report difficulty in gripping activities that involves the thumb, typically in gripping activities that involve the thumb, like holding objects, opening jar, buttoning claws, permanent loss of sensory axons. Disappearance of the pain is the late finding. So disappearance of the pain is the late finding. CTS actually is a clinical diagnosis for patient with classic symptom pain, paralysis, and examination findings, weakness, sensory loss in a median nerve distribution. Diagnostic accuracy increase the presence and the classic aggravating factor sleep, sustained wrist positions. Elevating factor is and shaking. Provocative maneuver. We can do some provocative maneuvers. For provocative maneuver, we can use the Phalen's test, we can use Tinel test, we can use Darkan test. Uh, if we look at this picture, if we look at here, can you tell me the name of the test? This is Phalen's maneuver. This is Phalen's maneuver. A flexion of the wrist compresses nerve inside the carpal tunnel. So flexion of the wrist compresses nerve inside the carpal tunnel. It induces hyperflexion 90 degrees of the wrist, causing increased carpal tunnel pressure. A positive test is defined as pain and paresthesia in the median nerve innervated fingers. Within a minute, this is very important, within a minute. The Tinel test involves tapping the carpal tunnel over the median nerve and is positive when there is pain and paresthesia. So light tapping elicits a tingling sensation. So light tapping elicits a tingling sensation. Look at this pic. This light tapping elicits tingling sensation over the median nerve area. Other test can be done the darken test. We can do a electrodiagnostic testing nerve conduction studies. Electrodiagnostic testing should be used to confirm the diagnosis of the CTS in any patient with atypical or inconclusive finding. It is also warranted for patients of being considered for surgical intervention, including those with moderate to severe and worsening symptoms despite conservative management. Nerve conduction study, what it indicates, it's showing slowed conduction velocity. Uh, it's showing slowed conduction velocity across the carpal tunnel, indicating demyelination. It's showing slowed conduction velocity. So slow conduction velocity across the carpal tunnel, which indicates demyelination, can confirm the diagnosis of the CTS. NCS can also identify axonal loss, seen as a decreased amplitude of the compound action potential, which indicates more severe disease and the need for surgical referral. Electromyography demonstrating denervation of the median innervated hand muscle, the abductor pollicis brevis, is frequently combined with NCS to confirm the diagnosis of the CTS. It also helps exclude median nerve dysfunction proximal to the carpal tunnel radiculopathy. Radiculopathy. Imaging studies are not necessary for CTS diagnosis but may be helpful during treatment using ultrasonographic guidance for glucocorticoid injection, or when atypical features suggest a mass lesion using MRI. Lab tests may be helpful when there is suspicion for underlying medical condition that increase the CTS risk, like hypothyroidism, rheumatoid arthritis. Management, if we look at the management of the CTS, it is based on the disease severity. For mild to moderate CTS, patient able to perform activities of the daily living ADL, no exon loss on NCS, and the trial of no exon loss on the NCS, and the trial of the conservative therapy is recommended. Patient with severe CTS interference with the ADL exon loss on the NCS, conservative measure fail conservative measures fail, should be offered surgical decompression. Non-surgical therapy, we can use wrist splinting, glucocorticoid injection, physical therapy, ultrasonography, and yoga. Wrist splinting is the first line treatment for uh, mild to moderate CTS. Splinting helps the patient maintain a neutral wrist position, preventing excessive wrist extension and flexion, which lowers the carpal tunnel pressure, provides symptom relief, and improves nerve conduction velocities. Nocturnal splinting is often adequate for relief, but some patients gain additional benefit from continuous splinting or specific use during exhilarating activities. Glucocorticoid injection methylprednisolone into the carpal tunnel region can methylprednisolone into the carpal tunnel region mm, can provide rapid can provide rapid improvement by mm, reducing tissue inflammation, and is helpful. An injection is helpful when splinting is adequate, but it may also be used as an initial therapy For patients wanting faster results with similar efficacy to splinting, combined therapy with splinting and injection may improve CTS symptoms better than either therapy alone. Oral glucocorticoids are a reasonable alternative for patients wanting to avoid injection, although they are probably somewhat less effective. Other non-surgical uh, therapies used for CTS is physical therapy, flexor retinaculum stretching exercise, nerve gliding exercise, flexor retinaculum stretching exercise. In here, outward traction is applied over the flexor retinaculum. If you look at here, if we look at this picture, there is outward traction applied over the flexor retinaculum. Outward traction applied over the flexor retinaculum. This is carpal tunnel release. So this is non-surgical therapy, flexor retinaculum stretching, nerve gliding exercise. We can give these to physical therapy. And therapeutic ultrasonography and yoga can be done. Non-surgical therapies without clear benefit, although commonly used, NSAID and have not demonstrated significant improvement for CTS patient. GABA, pentinoid, pregabalin, which are used for neuropathic disease, diabetic neuropathy, have appear to have negligible effects on the CTS, despite the role of the diuretics is decreasing edema and the relationship of the vitamin B6 deficiency to peripheral neuropathy. Neither has shown the benefit for the CTS. Surgical decompression is the treatment of choice for patients with CTS who have severe symptoms, weakness of the thumb abduction, weakness of the thumb abduction, or opposition, evidence of axonal loss on NCS, or mild to moderate symptom refractory to non-surgical therapies. Surgery for CTS involves division of the transverse carpal ligament flexor retinaculum to relieve pressure of the median nerve, can be performed by incision or endoscopy. For patients with moderate to severe CTS, surgical decompression results in greater improvement than the non-surgical treatment for both symptomatic relief and function. If we look at the differentials, what are its differentials? Cervical radiculopathy. The this is common and can mimic the CTS, causing pain, paresthesia, weakness. C6, 7, 8 nerve roots. However, cervical radiculopathy is often exacerbated with neck movement and is usually accompanied by some combination of the neck or shoulder pain, reduced reflexes, proximal arm weaknesses, reduced reflexes, proximal arm weaknesses, im- impaired elbow flexion or extension, and a dermatomal rather than the median nerve pattern sensory loss. Another is pronator teres syndrome, median nerve compression in the upper forearm when median nerve passes between the humeral and the ulnar head of the pronator teres muscle. All mm, so pronator teres syndrome can happen. So in pronator teres syndrome, there is compression of the median nerve in the upper forearm, compression of the median nerve in the upper forearm when median nerve passes between the humeral and the ulnar head of pronator teres muscle. When the median nerve passes through the humeral and the ulnar head of the when median nerve passes through the humeral and the ulnar head of pronator teres muscle. Although pronator teres syndrome causes pain, paresthesia in the first three digits, sensory symptoms are also expected, but thinner eminence due to proximal median nerve compression, which, unlike in CTS, includes a palmar cutaneous branch. There may also be weakness of the median innervated muscle proximal to the wrist, impaired wrist flexion, or forearm pronation. Pronator teres syndrome is rare, generally occur with repetitive, forceful arm movement in tennis player or bodybuilders. So PTS can happen in tennis player or in bodybuilders. So PTS causes pain, paresthesia in the first three digits, and sensory symptoms are also expected over the thinner eminence due to proximal medial nerve compression, which, unlike in CTS, so sensory symptoms also expected in pronator teres syndrome, but in carpal tunnel syndrome there is no sensory symptoms because the pronator teres syndrome also includes palmar cutaneous branch. There may be also weakness of the median innervated muscles proximal to the wrist. Median innervated muscle proximal to the wrist, impaired wrist flexion, forearm pronation. And the third is cubital fossa injury. The median nerve passes through the cubital fossa where it is susceptible of penetrating or mechanical trauma. So median nerve passes through the cubital fossa where it is susceptible to penetrating or mechanical trauma, laceration, supracondylar fracture. Sensory and motor symptoms can be identical to those with pronator teres syndrome, but nerve injury in the more proximal cubital fossa often results in inability to flex the index and the middle fingers, hand of benediction from the denervation of the flexor digitorum muscle that bend 2 and 3 digits. So if we look at this classic picture, this is a very ideal picture I would like to talk about. If we look at here, okay, look at this picture. Also, classic hand poses in radial, ulnar, and the median nerve lesion. So this is a classic hand poses. Injured nerve is radial. Context is attempting wrist extension, loss of wrist extension by extensor carpi radialis brevis, extensor carpi radialis longus, extensor carpi ulnaris. So wrist drop, radial nerve injury can happen, and there is loss of extension which is done by these muscles. And the ulnar claw, injured nerve is ulna, attempting to finger extension, loss of MCP flexion, and the IP extension, loss of MCP flexion and IP extension by the lumbricals, third and the fourth. This is ulnar claw. Median claw, distal median nerve attempting finger extension, loss of MCP flexion, and IP extension by the lumbricals 1 and the 2. So median claw happens due to loss of the MCP flexion and IP extension by the lumbricals 1 and the 2. And the final, the hand of benediction, distal or proximal median nerve involvement, attempting to make a fist. Loss of DIP flexion by the loss of DIP flexion by the flexor digitorum profundus to the index and the medial finger, and loss of PIP flexion by the flexor digitorum superficialis. And the intact FDP to the ring and the little finger preserves flexion. Loss of IP flexion by flexor pollicis longus. This is hand of benediction. Very, very, very high yield. The prognosis, because CTS often worsens time prognosis, and early diagnosis and treatment before permanent nerve damage can occur. Patients with mild to moderate CTS typically respond to conservative measures, but many patients ultimately require surgery. Better long-term outcomes approximately in the selected patient. Prognosis is worse, involves permanent numbness or weakness. For patients with advanced disease, axonal loss in CNS. In rare cases, CTS can lead to CRPS. CTS can lead to complex regional pain syndrome. Complex regional pains in a very so CTS can turn into complex regional pain syndrome. So that is all about carpal tunnel syndrome. It's a very brief discussion, but it's a very effective discussion. Hope you enjoy.